Hi, my name is Ellie.
And my name is Will.
Welcome to Lively Minds, the podcast about mental health challenges that go beyond the ebb and flow of the everyday.
The podcast that looks at how developing an understanding of our mental health influences how we address it.
In today's episode, we're talking about antidepressants, specifically the most common form of antidepressants, SSRIs, which stands for Selective Serotonin Reuptake Inhibitors. So we're going to be finding out what the evidence says about their effectiveness, as well as what kind of gaps remain in our understanding about them and what the kind of views are on their potential side effects as well.
To guide us through this conversation, we're joined by Dr. Alex Curmi from the Thinking Mind podcast. Alex is a consultant psychiatrist as well as a trainee psychotherapist. Through his podcast, he has been having some fascinating conversations with people on all sides of the SSRI debate.
So it is properly a debate, isn't it, really, with attitudes from different mental health professionals in different roles as well within mental health, ranging quite significantly in terms of how helpful they believe the medication to be.
Yeah, it's a debate that I have to admit I've often found quite unhelpful. Sometimes I think it can be difficult to see through the fog, especially when experts start using lots of biomedical jargon to make their points, which in turn leads me to worry about my own SSRI use. Speaking of which, it's really important to stress at the very outset that the following conversation should not be taken as any form of medical advice. So if you're taking any kind of psychiatric medication, please don't change your dose without talking to your doctor first.
So before we start, I just wondered if you, for any listeners who haven't heard the term SSRI before, if you could just very briefly, Alex, explain what they are, how they're prescribed.
Yeah, sure. And firstly, thank you so much for inviting me. It's an absolute pleasure to be with you. SSRI, of course, one of the most commonly prescribed antidepressants. SSRI stands for Selective Serotonin Reuptake Inhibitor. So what we know is we have nerve cells in our brain that connect to each other. Between the nerve cells, you have these things called synapses. Synapses are the gaps where we have neurotransmitters, chemicals that are released that signal between one nerve cell and another nerve cell. There are loads of different kinds of neurotransmitters. Everyone knows about dopamine, of course, serotonin, and GABA and other ones. SSRIs work on serotonin. So what you have is one nerve cell might secrete some serotonin to signal something to another nerve cell. And then over time, that serotonin is taken up by the cells. And what SSRIs do is they delay that reuptake. So they inhibit the reuptake, hence selective serotonin reuptake inhibitor. And of course, the fact that SSRIs do this has led to some discussion about how and why they may influence people with depression and mood problems, which I'm sure we'll talk about. But that's just a general overview of what SSRIs are and what they do.
Thank you. It would be really good, I think, just so that the audience is clear on what our general positions are on the question of SSRIs. Just for us each, just to very briefly give the headlines of our position when it comes to our perspective, our attitude towards SSRIs. Ellie, do you want to go first?
Yeah, sure. So I think Will thinks that I'm completely anti-pharmaceuticals and anti-pharmacology, and has wanted us to have a big argument on the podcast about this for ages.
That's what I came prepared for, a big argument. I was hoping that's what you were going to have.
No, well, maybe, who knows? But the bee in my bonnet I actually have is specifically about antipsychotic medication, which is different to SSRIs. However, I am super skeptical of any kind of purely biomedical understanding of mental health, because I think it leads to an overprescription of pharmaceuticals, and that ends up being a substitute for putting the funds and resources into treatments that can actually change people's quality of life, and other treatments, so talking therapy, social and economic policies that actually make people's lives a bit more bearable. And I do disagree with the idea that depression is a biological thing that you have. I do agree with Joanna Moncrief's sort of distinction of that, where being in a depressive state is the thing that's happening, rather than you have this biological sort of thing that you need to like treat and manipulate and then it goes away or something. And I have been on SSRIs for nearly 20 years, which is actually a really long time. And I don't have any plans to come off them particularly soon, though when I was adding up how many years I've been on them, it did freak me out a bit. And I would like to be in a sort of like safer and more stable life place where I would start to hopefully experiment with lowering the dosage and coming off them. So that's my position probably.
And my take is that I have also been on SSRIs for not as long as Ellie, but for several years. And I found them very helpful in tackling my mental health condition, which is more in the sort of anxiety and OCD space than depression. But that said, I do share Ellie's concerns that SSRIs are prescribed perhaps without enough thought about the sort of more socio-political circumstances around somebody's life and the things that might be impacting their life, and also maybe not necessarily being prescribed with patients knowing fully about the potential risks as well as the rewards of taking them. So yeah, I would say that I'm broadly quite positive about SSRIs because of my own personal experience and seeing the change that actually happened, particularly with my OCD after I started taking them. Alex, what's your headlines?
So my headline or my elevator pitch for SSRIs is probably similar to all antidepressants and probably similar to psychiatric medications in general, which is I think they can be useful tools, taking a very cautious, targeted, time-limited approach and making sure to be very transparent about what we know and don't know about these medications, what we know and don't know about the biological underpinnings of the mental health conditions that we commonly have. And I would say that I largely agree with both of your concerns. I do worry about the problem of overprescription. I do worry about the neglect of discussion around things like psychological reasons for having mental health difficulties, socioeconomic difficulties, political difficulties. I worry about all of that. I would say I don't know any psychiatrists that really rely on a purely biomedical model, maybe a small minority. But largely I find that most of the psychiatrists I've met and trained with are really kind of aware of this problem, and increasingly so. You know, one of the things that I think is a little bit disappointing about how the specialty of psychiatry really evolved is, you know, if you go back to the 50s, 60s, most psychiatrists were also trained in psychotherapy of some kind. And therefore, they got the benefit of inheriting a lot of the wisdom of psychoanalysis and other forms of psychological knowledge. And I think that was really amazing. I think when psychopharmacology really came around in a big way, I think psychiatry kind of saw that as a opportunity to be like, okay, let's be real doctors and we'll just concentrate on chemicals and biology and medicine, and that will make us feel like we're kind of more neurologists. And I think that really fits in with the biological bias that medically trained professionals tend to have. We really went hard in that direction. As late as the 90s and the 2000s and the 2010s, there was a real optimism that biology was going to revolutionize mental health. We discovered the genome and we mapped it, and we were going to find all the genes for all the mental health conditions, and we were really going to figure it out biologically. And drug therapy was going to be a part of that. That hasn't really panned out. And so I think starting with roughly where I started training and maybe the generations of psychiatrists and mental health professionals training below me, there's this increasing concern that we've become divorced from a lot of really good psychological wisdom that is limiting our ability to treat our patients effectively. So, but all of that being said, coming back to my original point, I think these can be useful tools with a ton of precautions and a ton of transparency.
Could you then tell us a little bit about what the debate around the effectiveness of SSRIs actually is and how significant it is?
That's a good question. I don't know if I can say what the debate is exactly or how significant it is. I'll tell you what I've seen. The debate about antidepressants is largely reflected by the debate about depression itself. And so there's I think people who are more within the mainstream or of academic psychiatry, particularly, who are really concerned about the biological underpinnings of depression, and therefore that depression should have a biologically based medical treatment. And they feel that antidepressants have been useful tools for some decades to help people with depression. And there is some evidence for that. There's another subset who probably would say, actually, we're not sure about these biological underpinnings for depression, but the medications do seem to work, and therefore their use is justified on that grounds. And then there's another side to this debate, which is something like depression has no biological underpinnings, and there isn't any convincing there isn't any convincing evidence that antidepressants are useful treatments. And therefore, depression as a medical or biological entity and antidepressants as viable medical tools should just be disregarded. That's more Joanna Moncrief's point of view, who I interviewed on my podcast. And I would say that's not exactly where I am. So what I would say is I would agree with her that we haven't really delineated depression biologically, and that's the problem with all mental health conditions. Mental health conditions, the diagnoses themselves, they're not based on causes. They're based on outcomes. Like depression is an outcome, mania is an outcome, suicide is an outcome, and they're complicated behavioral and experiential outcomes. Like any psychiatric symptom is one of two things. It's either someone's behavior or someone's experience. That's it. All psychiatric symptoms fall into one of those two categories, whether it's a hallucination or an impulsive act, or difficulty concentrating. Look at medical conditions. Often the conditions themselves are pointing to a cause. So like type 1 diabetes is a failure of the pancreas to produce insulin, or COVID-19 is a specific virus causing a specific collection of symptoms. Whereas with psychiatry, we have the outcome. It's a bit like if we diagnose people as having a cough, right? But one person might have a cough because of COVID, and another person might have a cough because of tuberculosis. Two very different causes, but they have an outcome that kind of resembles each other, the cough. That's kind of where we're at in psychiatry. I think a lot of psychiatrists suspect that depression is probably a group of conditions, if it is a condition at all. Similarly, there may be subtypes of things like ADHD. There may be subtypes of psychotic illnesses, or the way they overlap with a mood problem like bipolar. So all of this is the bedrock underneath the debate of then what does that mean about the drugs that we use? And I said there are these different camps. There's the camps that feel actually we kind of know how they work, and therefore we should prescribe them. There's the camp which I subscribe to, which is we don't really understand how they work, but they seem to be safe with the right precautions and effective in enough cases that they're worth trying, albeit with the precautions. That's my camp. And then there's the camp that's like, there's no biological underpinning and there's no convincing evidence that they work at all, or the risks, the harms outweigh the benefits, therefore we shouldn't prescribe them. So I think that's kind of an overview of the landscape.
That's really helpful. Thank you. You mentioned it briefly before about the growing prescription rates of SSRIs in the UK. And we have seen a massive increase in the last 10 years of, I guess, primary care prescriptions for SSRIs. I was going to ask what's your view on it, which I'm still asking, but also wanted to ask, do you distinguish in that between overprescription as a frontline treatment and overdosaging almost? Do you see what I mean?
Yeah. I'll talk about overprescription first. Often, something I've kind of come to believe in philosophically is that strengths and weaknesses often aren't as separate as we think they are. I think something's strengths and something's weaknesses are often joined at the hip, two sides of the same coin. So if you take antidepressants, and really David Taylor, who is the lead pharmacist at the Maudsley Hospital, and he authored the Maudsley Guidelines, which is one of the leading psychiatric medication prescription guidelines globally. The reason people understandably gravitate towards antidepressants is because they're fast, they're quick, and when they work, they can provide that quick relief of what are really quite debilitating symptoms. Like if you've ever been depressed, you know it's a really debilitating thing to experience. And when antidepressants work, they can provide some decent relief of those problems in a few days to a couple of weeks. And that's a big deal, because even though there's tons and tons of options on the menu when it comes to treating depression, they're generally not as fast. That's the strength of antidepressants. But as I said earlier, I think the strengths are often tied to the weaknesses. The weakness of antidepressants is you can just prescribe them quickly, and that can give you the opportunity to ignore all of the other things that's going on in that person's life. Now, as I said before, depression, like every psychiatric condition, is just an outcome. And because it's a complicated experiential and behavioral outcome, it's going to be influenced by all sorts of factors, ranging from that person's genetics to, yes, maybe some of the underpinning biological realities, still pretty mysterious though, their social life, their nutrition, how much they exercise, their psychological problems, whether or not they're in a good relationship, how many friends they have, how much time they spend outside, whether or not they feel they have meaningful work, whether or not they're in an existential quandary. You get my point. There's all sorts of inputs going into this, and those inputs take a long time to examine. Prescribing an antidepressant does not take a long time. That's a really good thing. But the underlying problem, the underlying weaknesses, we can become overly reliant on that. We can decide to not, go through all of those different factors that I mentioned. And it's worth mentioning that most of this antidepressant prescription is happening at the GP, the family practice level. And I am not in any way knocking GPs or how they practice. GPs are under incredible amounts of pressure. They're basically forced to see people in tiny appointment times of 10 minutes, which as a psychiatrist, I can't relate to at all. I have the luxury of spending at least half an hour, 45 minutes, sometimes an hour and a half with a patient and get to dive into every aspect of their history. And GPs don't have that luxury. And I don't think it's really any individual GP's fault. I think it's kind of a systemic problem that needs a systemic solution. But I think this reliance on the speed of antidepressants and this hope, as I said, that started really in the 90s and 2000s around antidepressants, that they were going to fix everyone's depression, it's led to this problem of overprescription. You asked the question about dosage as well. What I have seen, unfortunately, in my practice is, often patients with depression will start on an antidepressant, it'll have a bit of an effect, then the effect will wear off. That happens with drugs. It's called tolerance. And then the doses are increased. And then if the effect wears off at the point where the dose is maxed out, then either another antidepressant is added or the antidepressant is changed. And that can happen so on and so forth for years without ever talking about all of those other factors I mentioned. And that, in my opinion, is a tragedy, is the biggest problem we have around depression, in my view.
Yeah, that's what kind of concerns me most about the overprescription thing. It's not so much the fact that more people are, this is also a concern, that under first line of treatment being started on like the lowest dose of citalopram instead of kind of other things being investigated for all the reasons you just said. But also the things, all I can see in my head is a pattern of, if that keeps happening, what you just described, what kind of drugs and strength of drugs is that person going to end up on in 6 years' time once they've mapped out the frontline SSRI? Is it then adding in this? At which point is the side effects producing other things that then get treated? And it can end up being really quite a serious situation from kind of what was initially intended as a plaster to try and cover a short period of time.
Yeah, and David Taylor says, we should be thinking about antidepressants in the same frame of mind we think about antibiotics. Short, targeted, very carefully looking at benefits and risks and side effects, and being very quick to stop if the risks outweigh the side effect, if the risks outweigh the benefits. And that's something I've seen over and over again in my practice. I really can't emphasize how much I've seen this, is patients just remaining on antidepressants for 2, 5, 10 years. The doctors aren't checking in with the patient about how this antidepressant is working and whether or not it's worth continuing to take. And most tragically, the patient isn't checking in with themselves. And I think I'm not obviously putting all the responsibility on the patient, but I do think we should be able to create a culture where this kind of check-in happens very frequently, and patients are really encouraged to take care of and think about their medicine in a proactive sense. And I also think, sort of on this point, because we're talking about antidepressants and depression really in the mild to moderate population.
Yeah.
So if you think of like the huge circle of people in the UK with depression, we're talking about the two huge outer rings, the vast majority of people who have mild or moderate depression. It is my belief that for most of those people, although depression is, yes, debilitating and unpleasant, it's also a useful signal that something is not quite right in that person's life. And that is not like a fault thing or a blame thing. It's not a moralistic judgment. I think that the evolutionary process gave us this thing called a mood and a system of emotions for a reason. And that is a signal light to tell us something might be not quite right. Now, what it is, hard to say, because you need to do an individual analysis of that person's life. And I would also want to mention that modern life has gotten more and more complicated and more mismatched to the environment in which our brains evolved. That's an evolutionary perspective, and I think that's a huge problem. And I think in the modern West, people are being called upon to look after their mental health implicitly in a way that we've never had to in human history, because our brains were more matched closely to our environments. And now in modern life, I think people find themselves on their own, surrounded by quite alienating technology in very strange foreign circumstances as far as our brain is concerned. And this poses all sorts of challenges. But I think it's really worth understanding that mood problems can be a very useful signal, just like having a check engine light on your car can tell you something's wrong. I think for many people, it's a useful signal that yes, we want to relieve the suffering, but also we want to try and pay attention to what that signal means. And maybe that's one of the biggest things I see missing in our culture. And that's something that's more addressed, for example, in the world of psychotherapy.
So could you tell us then what we know about the effectiveness of SSRIs? I guess there's sort of almost two parts to this question as well, which is, on the one level, one of the debates appears to be whether or not they work, and then another debate appears to be how effectively they work as well. Could you just sort of take us through that?
Yeah, so I got this information from David Taylor, who I mentioned earlier, head pharmacist at the Maudsley Hospital. And he, no one really knows the research better than David. He's seen the published studies. He's seen the unpublished studies. He knows why some studies are published and why they're not. You're not going to get better data than him. He would say all antidepressants, and this includes SSRIs and other antidepressants, overall have an effect size of 0.3 if you take into account just the published studies. If you take into account the unpublished studies, they have an effect size of 0.2. So what does this mean, this idea of effect size? So effect size is kind of a standard way of measuring how effective a medication is for treating a condition in all of medicine, physical health and mental health. And generally speaking, if a medicine has an effect size of 0.2, 0.3, it's considered small to moderate. 0.5 is considered like significantly more moderate, and then 0.9, 1, 1.2, that's like a big, really convincing effect size. Just because 0.2, 0.3 is small to moderate doesn't mean it's not useful. And then you also have to so for example, if a randomized control trial shows a particular antidepressant to have an effect size of 0.3, what that means is the average person in the treatment arm who got the antidepressant as opposed to placebo is probably better off in terms of their depression than around 62% of people in the control placebo arm. So it's actually quite a big deal. And also what that effect size maybe doesn't capture is some people are going to do really well. Like some people, when they get an antidepressant, it really works quite effectively. Some people are going to have no effect, and some people are going to be worse off because of side effects. So the best way to summarize the treatment of the effectiveness of antidepressants is kind of around 0.2 to 0.3, which is a small to moderate effect, similar to something like cognitive behavior therapy for anxiety, for instance. So reasonable but small.
Just wonder if there are many other medical conditions and drugs that are prescribed with such readiness when the research to back it up is kind of the level that we have of the SSRIs and only having a 0.2 or 3 effectiveness.
Yeah, so I actually did a bit of research on this, and it's quite common actually.
Okay.
So if you look at something like aspirin for heart attack prevention, and it's worth saying like aspirin is it's a standard part of heart attack prevention, but it's a pretty small piece of the puzzle, as I think antidepressants should be, incidentally.
Yeah.
And that would have an effect size of about 0.22. And I also found a study saying like statins for heart attack prevention, again, a small piece of the puzzle, that's about 0.30. So it's pretty common. But what you want to know, what you want to let the patient know with antidepressant prescriptions is the potential for side effects, the potential for withdrawal symptoms, and again, targeted, time limited. And you also want to do that thorough assessment for their depression, taking into account all those factors I mentioned, so they realize they have options, and that especially for the mild to moderate cases, I think whether or not to take antidepressants is a personal choice.
Yeah.
That should be contextualized within all the other things, within all the other options that a person could choose to treat their depression. And that could include exercise, again, looking after their nutrition, trying something like psychotherapy, trying something like couples therapy if they're in a marriage, and that might be a source of the problems with mood, looking at their job and how they spend their time, all those things. So I think you have to mention the effect size, but you also have to mention the potential negative effects of antidepressants, and you have to mention all the other options and do that really thorough assessment so they can say, okay, this is a overall small piece of the puzzle here. And again, no shame if given all that information, a patient wants to proceed with an antidepressant, and I think with the right precautions, it is safe. But yeah, what I would echo your worries that I don't think this is happening most of the time, that an antidepressant is prescribed. And perhaps this is what we're all starting to slowly wake up to as a society.
One thing that it seems to be from my perspective, which obviously is very much a layman's perspective, so I've got no idea how true this is, but it seems like the research into the effectiveness of SSRIs is very heavily focused on depression, on the treatment of depression. Whereas, in fact, of course, SSRIs are used for a whole range of mental health conditions. I mean, they're used for, from listening to your podcast, I realise that they're used for other things as well. But, they're used for treating anxiety, PTSD, OCD. I mentioned earlier that for me personally, it seems, from what I can tell, that the SSRI that I take has had quite a good impact on my personal situation when it comes to OCD. So how much evidence is out there, would you say, about the effectiveness of SSRIs on these other conditions?
I think I'm not an expert on all of how antidepressants have been researched for all of those conditions. They've all been studied and they've all been shown to be effective, probably with a similar effect size, but you don't quote me on that.
Well, funnily enough, I actually remember Professor David Taylor saying words to that effect on the interview that you had with him, which is it's kind of, roughly speaking, a similar story, really, in terms of the effectiveness. But
what I would add is, with all of those conditions, again, you need to look at root causes and psychological intervention. So especially with trauma, you're going to want to see if you can help the patient process that underlying trauma. That would be ideal. And now there's, trauma-specific therapies like EMDR, for instance, for PTSD. Anxiety, what I don't think enough people understand is anxiety is really amenable to psychological approaches. Especially if you're anxious about a specific thing, like a phobia or a particular situation, like being in a crowd. Exposure therapy is one of the most reliable things that we know in psychology really treats anxiety well. Exposure therapy is obviously way more uncomfortable than taking a medication, but it's really effective. And more than treating your anxiety, it helps you become, a more resilient person. And that's kind of one of the reflections I end up having in my journey, kind of training and doing my podcast is, personal development and growing your capacities as a person is really the other side of the coin of treating your mental health. They're, again, joined at the hip, I think. The less you take the time to develop yourself, in my view, and maybe this sounds a bit harsh, I don't know, but the less you take the time to develop yourself, the more vulnerable you are likely to be to developing a mental health condition, and vice versa. So, yeah, I think drugs can be useful for those conditions too, but you're gonna also be wanting to see what can you do in parallel to treat things a bit more definitively.
Yeah, I agree with that so much. If you just take a very kind of absolutist, like, oh, I can't do that because I've got this depression thing that's totally separate to me. It's a weird avoidant comfort to some people who have it, and they take comfort in the fact that it's this separate thing that I have, and therefore I can't do this, this and this, but that's what it is, and I have medication for it. When actually, how we grow and develop and mature emotionally and build resilience is through working on ourselves all the time. And that's another reason I feel so uneasy about it, because I've had conversations lots of times with people who are very much like that. And I'm like, but this means you're not doing any self-reflection on why you're not happy.
And what you've just said is one of the things I spend the most time thinking about, which is to what extent is diagnosis useful versus to what extent can diagnosis become a kind of crutch or a limiting belief or the beginning of a set of limiting beliefs. And it keeps me up at night, honestly, because I think you can make such a strong case for both. In some cases, in some situations, it's so useful to have a professional say, you have a set of problems that we recognize, that there is treatment existing, that it's not super, there is some mystery, but it's not entirely mysterious. There is this thing called depression, when people get really low in mood and they lose their appetite and they wake up really early in the morning and they feel like a lack of pleasure from their day-to-day lives. That's a thing we understand. And there's this whole menu of options to treat it. That's super useful in so many cases. Equally, you can have situations where people, just like you said, might say, oh, I can't because of fill in the blank. And that problem keeps me up at night. So thank you for raising it.
Yeah, I agree with you both, maybe with a slight caveat, which is that I think there's something. One thing that I realize about my sort of journey with taking SSRIs is that I spent about 15 years not taking SSRIs. So I was I think probably unusually, perhaps late. I wasn't subject to that kind of liberal prescribing challenge that we've been talking about. And so it was a good 15 years after trying a whole range of different sort of psychological treatments and having a whole range of different types of therapy all through the NHS, that I eventually just sort of went, I'm going to try SSRIs now. I'm going to try medication now. And now, it's now 7 years that I've been taking them, and I am sort of thinking to myself now, and I have had a conversation with the doctor about at what point it might be time to start, thinking about coming off them. In a sense, it's almost like trying to turn it around so that the first line treatments are actually those more psychological interventions, and also, of course, looking at sort of that broader socio-political picture and trying to just improve people's lives and sort of support that. It's almost like those should be the first line interventions, and then if that doesn't work, or if there's still ongoing challenges, that then SSRIs could become a part of the solution. Although I do take what you said earlier, Alex, about how one of the attractions of SSRIs is their when they do work, their relatively fast-acting nature, which I guess is one of the reasons why they are so often used as first line.
Another thing to add in favour of that last bit that you said, actually, is also that sometimes even when the things are very obvious of what is making someone's, war, bereavement, when something's really obvious, it's not always something that either the medical profession or that individual can actually do anything about, and that is also I do acknowledge that as well. And
the other point I would mention as well is that there is still a lot of stigma and shame about taking medication.
Absolutely.
And I think, even though I have my reservations about psychiatric medication, I think the shame and stigma is unwarranted and not helpful.
Yeah.
You know, we're having this conversation now about drugs like Ozempic and Mounjaro, which incidentally, those have huge effect sizes of like 1 or 1.2 or something like that. Those are the big guns. So we know they're effective and we know how they work. But there's shame about, you know, should you use a tool like a drug to help with your mood, or should you use it to help with a weight problem? And I think this is just, to be honest, a bug in the humanities software, in that we tend to, I think we can make an evolutionary argument that we make moralistic judgments about people's behaviors and their outlooks, which then causes us to make moralistic judgments about using medications as an easy way out or a shortcut.
Yeah.
And I think that's totally inappropriate. I don't really subscribe to that.
Yeah, that's like the bane of my existence. Because I've got lots of physical health problems and chronic health problems, I probably get sort of like advertised or bombarded more often than others with this kind of content. But like, it's gone in hand with the kind of, you know, taking medication goes against the kind of current trend of both like, you know, hack your way into being your ultimate self, and also it's viewed almost like as an opposite to kind of nature and diets and nutrition, and people on the extreme side of both of those, there are moral judgments on someone taking medication, and it's horrendous. And
people judge themselves, like I'm taking medication and therefore, you know, I'm weak, or there's something, you know, inadequate about me. And it's like, if you're lucky enough to live in a society that can avail you with certain tools,
that can prescribe you medication.
Yeah, absolutely. Use them if they work. You know, they're just tools.
Life's really hard, and I always, no matter what it is, even if it's kind of an unhealthy habit, I always just think people should sort of remember that life's really hard, and a lot of things people do, they're just trying to use what tools they can access to make it more bearable.
Yeah, and expanding on the point I made earlier, like modern life is really strange. It's changed so much. I'm sure if you guys reflect on what your lives are like when you were children to now, the change is enormous. I certainly feel that way, and it seems to be only getting faster. It's totally bewildering.
Yeah.
We've never really been in a position like this. And again, if you think about what it was like to be a human throughout most of human history, you probably had very little authorship over your life. You're kind of just thrown into a tribe or a civilization. You're probably locked into place. You had a very specific set family. You probably only knew a small amount of people. There's only a tiny amount of people you really could know, probably as when we were hunter-gatherers, Dunbar's number, like 150 people, maybe 200. But even if you go into medieval times, what's the maximum amount of people you could know in a lifetime? Probably way less than now, where we can use something like a dating app to send a digital brochure of ourselves to millions of people in a large-sized city. It's totally insane. And so with that, we have more choices than ever. And we in the West, we love choice. We worship choice and freedom. But choice and freedom past a certain point, it's kind of like money, where if you go from like no choices to a bit of choices, that really increases our happiness and really gives us a sense of autonomy and authorship, and that's great. As soon as we go past a few choices, there's like a famous TED talk about this, it's totally bewildering and anxiety provoking. If you go from like 3 choices to like 10 or 50 or 100 choices, it's bewildering because it's way too much to process. And then you're burdened with the anxiety constantly of, am I going to make the wrong choice or not the best possible choice? Or am I going to have a worse outcome than my neighbor, and so on and so forth? And all of that, I think, is manifesting in the myriad of mental health challenges we see now. Even the rise of safety, like we live in really safe societies, safer than ever before. But safety isn't good for anxiety. Like having safety makes anxiety worse because we're not exposed really to challenges, and we don't often give ourselves the opportunity to face challenges, which is the thing, that's exposure therapy. That's what decreases anxiety. Again, I'm not arguing necessarily for a dangerous society here, but we have to understand the second and third order effects of the civilizations and cultures we build, that often we become victims of our own success. We build a really safe society, and we become more anxious. We build a really comfortable society, we become less resilient. These are all problems I think we really need to start thinking about and taking seriously.
What do you make of the debate around how SSRIs actually work, and to what extent do you think the question matters?
I think the question does matter. I don't think the question is 100% necessary to prescribe them. There are many treatments in medicine where we don't know precisely how something works, as long as it's reasonably safe with the right precautions and we can see that it's having a benefit for the person involved. I don't think it's mandatory, but of course it's a very useful question, and it's a question we need to try and answer to the best of our ability. What I can tell with antidepressants is there's nothing convincing. There's not enough convincing research, and Joanna Moncrief makes this argument really well. There's nothing definitive to say, okay, this is how they work. Perhaps it's affecting the serotonin system in different ways, and I think you can make a case that the serotonin system can affect mood and all the things that go along with mood, but it just hasn't been demonstrated scientifically what's happening in the brain with depression, and therefore, what's happening in the brain under the effect of an SSRI that's helping that person. So I think it's still pretty mysterious. Some psychiatrists may disagree with me on that, but I personally believe, even though we haven't really answered that question, they can still be useful tools in some cases.
In your practice, I presume you've experienced like both prescribing people SSRIs, but also supporting people to come off them. I just wondered if you could tell us a bit kind of what that's like when you're working with people to come off an SSRI, and how you kind of work with someone to sort of distinguish between withdrawal symptoms and kind of a return of significant symptoms.
Yeah, what I would say is I don't end up prescribing a ton of antidepressants in my practice, and neither do I end up weaning people off a lot. That's more because of the idiosyncrasies of my career and the different things I do than for any other reason. But what I can tell you about helping people come off antidepressants is, like, for many people, it's fine as long as they do a reasonably slow taper. Obviously, whatever antidepressant you're on, whatever dosage you're on, you should speak to your doctor about this. If your doctor doesn't think you need to taper at all, then probably seek a second opinion. But you, generally speaking, want to reduce an antidepressant slowly, and you want to kind of find out, are you in the category of someone who has withdrawal symptoms, which is, I think, still kind of a minority overall, although it's common, or are you in the majority who probably you'll be fine and just a reasonable taper would be sufficient. If you start to lower your antidepressant and you find, actually, I'm starting to get withdrawal effects, and those could be anything from like headaches to brain zaps to appetite disruption, sleep disruption, sometimes anxiety, sometimes mood can come back. Then you want to go back up to where you were before and just hold it there for much longer. You basically, if you're starting to get withdrawal effects from antidepressant reduction, you just want to go extremely slowly and do a holding pattern at each dose reduction way longer than you think is reasonable. And that might be like a month at a particular dose, or 2 months. And it might come down to really cutting the tablets finally. The best person to look up about this is Mark Horowitz, who I had on my podcast. Maybe you guys can put a link in the description. And he has a website where he goes through all of this and how the protocols for coming off antidepressants.
Cool.
I think something very important for people to know is, especially if you're in that group who have withdrawal symptoms, is it's not linear, because basically drugs occupy receptors in our brain. And you would think, okay, if I reduce the drug by 50%, I'm going to reduce how much the drug takes up the receptor by 50%. But it's not like that. It's not linear. So what you might find is you might go from 100 milligrams of a drug to 50 milligrams and reduce by a certain percentage. But the 50 to 25 milligram reduction reduces the receptor occupancy by a much bigger percentage because it's a non-linear process. And that's why people might be coming to the end of their antidepressant taper, and actually the withdrawal effects come hard and fast. And if that's the case, then you want to go back up, hold there for ages, and then go down really, really slowly and cautiously to try to minimize those withdrawal effects. But if you want to look up more about that, Mark Horowitz is the guy. I'd also like to just briefly mention There are other sort of biologically based tools that we can use for depression, particularly TMS, transcranial magnetic stimulation, and newer forms of TMS that are being pioneered in places like Stanford University in the US with different kinds of protocols of how you apply it. And those are potentially really promising as well. And there are other kinds of drugs being researched, like psychedelics, like psilocybin and ketamine. And I think, as David Taylor told me when I interviewed him, there tends to be a lot of optimism in the beginning, where they think, oh, we're seeing these huge effect sizes and no side effects. And then generally what happens as science progresses, you'll find the effect size generally wears down, and maybe new risks and side effects will crop up, and you realize it's not great for everyone. But that's fine, because it's still just another menu in the menu of options. And the more options a patient has, the better, in my view, especially the more sort of different types of options a person has. So I think good to acknowledge there are other kinds of treatments as well, besides sort of conventional antidepressants and SSRIs.
I really like that way of thinking of it, as like just sort of more options to add to the menu that you can choose from.
Yes.
I think that's a really nice way to...
Yes, and maybe the very last thing I'd say is I am optimistic, possibly, about AI and the combination of AI and psychiatric genetics, maybe to help us understand and predict who is going to respond to what better, just because of the sheer computational power that AI might give us access to. Perhaps it's a tool that will help us understand, oh, okay, this person needs sertraline at 100 milligrams versus this person needs psilocybin. And I'm aware that I'm probably sounding really close to that 90s, 2000s optimism that we're going to biologically unravel it all. Maybe I wouldn't go that far, but I would say, yeah, maybe...
No, you think we're going to technologically unravel us all?
Maybe AI-powered research will help us target our drug treatments a bit better. That's going to be my cautious
prediction. Interesting. Yeah. Thank you so much, Alex, for coming on. It's been really great to meet you, and that was really, really, really interesting. So thank you a lot. And thank you everyone for listening. As always, you can find us on social media at Lively Minds Pod.
Make sure that you subscribe to Lively Minds wherever you get your podcasts, and tune in again next month for another episode.
Please note that this show does not constitute medical advice and is not a replacement for seeking professional help. You can find signposting and support on our website, livelymindspod.com.
Please check out the Thinking Mind podcast that is presented by Dr. Alex Curmi. And you can also hear on there the 2 interviews that we've frequently referred to in this conversation with Professor Joanna Moncrief and Professor David Taylor. Take care, and bye for now.
Bye.